Welcome to the Troy University Athletic Training Program Preceptor Training. My name is Danielle Platt, Clinical Education Coordinator with the Troy University Athletic Training Program. Let me start off by thanking you for accepting the role of being a preceptor to our students. It is with your help that our students will be able to graduate with the very best athletic training education. During this training, we will discuss a variety of means in which you can adapt your preceptorship to best fit your student as well as yourself. I will first give you a bit of information about the program here at Troy University, and will then highlight those key aspects of preceptorship. The Troy University Athletic Training Program has always strived to grant each of its students the best education, both academically as well as clinically, to prepare them for the field of athletic training. Our program has adapted over the years to fit the requirements asked of the field of athletic training, but has always held true to its overall mission, to provide quality, didactic, and clinical experiences to its students. We strive to accomplish this through interactive instructional methods, such as the ones you will provide to our students, and expose them to every opportunity available. We have formulated goals and objectives to demonstrate to the student the education needed to recognize each of the responsibilities needed to provide quality healthcare to their patients. At your convenience, please read over the goals and objectives we have for our program. It is our philosophy that balanced developmental learning will ultimately provide the education to produce quality healthcare providers. Through the exposure of real-life, hands-on opportunities, progressive learning, challenging and stimulation experiences through a variety of preceptors and patient types, we can be sure we produce such providers. As a preceptor, you play one of the most crucial roles in this plan. By understanding what it means to be a mentor versus a supervisor, and how to give quality feedback through appropriate questioning, you will be able to give that quality clinical experience our students deserve. Levy et al. Describe a mentor as to serve as a mentor or a tutor, a person charged with the instruction and guidance of another. At the end of the day, you have accepted the role of being the student's mentor. Over the next few weeks, you will tutor them in the art of athletic training, if you will. By guiding them through evidence-based, quality healthcare, you are showing them what it takes to be an athletic trainer. You can complete this goal by providing quality supervision. Now, as Levy et al. Again describe, supervision is the action, process, or occupation of supervising, critically watching and directing. But what I urge you to understand that in order to provide quality supervision, you must tailor it to the individual student, just as if you were to tailor a rehabilitation plan to your individual patients. Each patient is different, as is each student is different. Levy et al. Provide us an excellent representation of this idea. Considering the different levels of students that we have seen within our athletic training program, you can tailor the supervision of your students to fit their educational needs. Looking at this model, beginning in the lower right, with the novice student, or what we consider the sophomore, our first years, their developmental stage would be number 1. They can be considered very enthusiastic and eager to perform in the clinical setting. Supervision level 1, or S1, the preceptor uses the directing to make sure the eager novice students understand the tasks, but does not provide much support since they are more likely to be the first to volunteer for tasks, or at least we hope so, right? Developmental stage 2, or D2, these can be considered the early competence learners or students. They might have some self-confidence that might be a little bit low because they begin to realize they don't know as much as they thought, i.e. they completed ankle tape job but stumbled through the steps and it is very wrinkly. These students need more of a coaching style of supervision. The student is still learning the task and may feel frustrated if the task isn't turning out the way they want. They might need more positive, sincere feedback that is timely and specific. The developmental stage 3, or D3, these students are the students who are becoming more proficient and competent at performing the necessary skills, but may hold back because of they might have earlier self-doubt. So you can consider these the junior levels or the second years. This student will need more supportive type of supervision. They will need clear, specific encouragement and recognition for the achievement of the desired task at hand. Finally, your Division 4s or your D4s students are confident, knowledgeable, competent students. These students are the ones you can rely on to be your second hand. This type of student will need very little, if any, direction and support. They will desire more separation from their preceptor and involved in more decision-making opportunities. They should also be given the task of being a mentor to the inexperienced students, if available. The Troy University students you currently have will more likely be within this fourth developmental stage, but I encourage you to take some time before you start to really get to know your student and decide for yourself where they fall on this spectrum. Feedback plays a crucial role in being a preceptor. As highlighted by Levy et al., students value preceptors that have good communication and instructional skills, optimize learning opportunities, provide clear and immediate feedback, and demonstrate sensitivity to student needs. Feedback can be delivered in two ways, either correctively or directively. Corrective feedback lets the students know their knowledge and skills are correctly being applied, as well as helps them develop a basic understanding of what is being asked of them. Directive feedback allows different possibilities, as well as uses additional resources to improve quality of action. I encourage you to be very specific and very clear with both of these, though. It can get a little confusing for the student if you're not. Each student responds differently to feedback. We can see an example of the different means of feedback here. For example, this tennis player's blister looks infected. I'm going to scrub it with peroxide, okay? Says the student. Corrective feedback would be, I agree it looks infected. However, peroxide is not the appropriate solution to use in this situation. Let's debris with saline. The other form of feedback could be directive. I agree it looked infected. Peroxide is very harsh treatment. What other options are available to you to treat this condition? Find which method best fits your student's understanding of what it is you are expecting of them. Questioning is another way to provide quality feedback to a student. Questioning is the conscious adaptation of the timing, sequencing, and phrasing of the questions in order to facilitate student processing. Consider this continuum. This is how much you and your student will more than likely interact on a daily basis. Your student will be working through a situation, and through your observations, you will provide feedback either through a question or statement. Your student will then respond in some way, and then you will provide the appropriate feedback to allow the student to decipher what to do from there. Either correct a mistake or understand what they did correctly to accomplish the task before them. Questioning assists in the development of skills, it supports discovery, as well as enhances critical thinking skills. Consider your questions on the what, the so what, and the now what levels. Each level of question allows the student more autonomy in their education and be the means of retention for them. The what level poses questions that check and reinforces the student's memory. The so what level pose questions that help the student sort through information to apply the concept, as well as the now what level, which poses questions that force the student to make a decision, asks their educated opinion, as well as find solutions. For example, an athlete whom you have been working with the past few weeks for a mild hamstring strain asks your junior level student for a moist heat pack during pre-practice treatments. The what level of questioning would be, what are some indications and contraindications for moist heat packs? A so what level question would be, what are other treatment options for this patient's condition? A now what level question would be, is this the most appropriate treatment plan for this athlete? So as you can see, each level of question can be appropriate for any level of student, but really it's dependent upon the student that you have in front of you and where you think can help their retention of information. Now, given all this information, it can feel like we are asking a lot, but being a preceptor can mean nothing more than 1 minute of quality interaction between the preceptor and the student. Curtis developed a method called the 1 minute preceptor to help accomplish this goal. The OMP, the 1 minute preceptor, involves the use of 5 micro skills. Get a commitment, probe for supporting evidence, reinforce what was done right, correct the mistakes, and then teach a general rule. The first skill, get a commitment, it gets the student to process and communicate the information they have obtained. It can also promote an open-ended questions. So for instance, what do you think is going on with this patient? And they can respond with their thoughts. Also, be sure you're listening for incorrect responses. And then allow them to promote ownership of their own education. So not only do you give them the opportunity to kind of talk themselves through the process, but also be sure that you're there to back up their process and give them evidence-based information. The next skill, probe for supporting evidence, allows you to explore the student's thoughts. For example, you could ask the student, what did you find in your exam that led you to your diagnosis? Again, just one more method of allowing them to refer back to what they just gained and walk themselves through the process. Be sure you're allowing them leading questions in order to kind of help spur up those thoughts. Please, please, please avoid any kind of negative tones. This is crucial at this moment. Allowing the student to refer back to their thought process might allow them the opportunity to correct their own mistakes, but we'll come back to that in a second. Next, reinforce what was done right. Again, going back to feedback. Positive feedback is crucial. This is also a really good time to use after you get a commitment, once they've committed to their information. You also want to be specific. Good job ruling out that MCL versus correct mistakes. This skill should occur simultaneously with reinforcing behaviors. It can be initiated by both the preceptor and the student. We hope that the student is mindful of their mistakes and is willing to admit and correct them themselves, but sometimes this responsibility falls on the preceptor. Again, be as specific as possible. You are right to rule out the MCL, but remember that the medial meniscus could also be involved based on the mechanism of the injury. Sometimes it's hard for the student to put all of this together. So a little bit of probing and a little bit of a boost, if you will, can help the student figure out what they did wrong, or at least what they could do better next time. And finally, teaching a general rule. Don't get bogged down with this one. A lot of times preceptors feel like they need to constantly be giving the student all these little pearls of wisdom, as we call it. Sometimes that's just not the case. Just teaching a few evidence-based pearls can be applied in future cases is sometimes the best education a preceptor can give. It can also further encourage additional review and reading, which is the golden word in our opinion, retention. We want as much retention as possible. Let's quickly walk through an example conversation of the implementation of the 1 minute preceptor. The preceptor asks the student, why don't you go ahead and take a look at him, the athlete, and tell me what you think. Junior student completes an incomplete evaluation, but states to the preceptor that they are ready to report their findings. The preceptor asks, what do you think is going on with him? This preceptor at this point is asking or getting a commitment. The student says, well, I think he has impingement syndrome. The preceptor asks, what did you find in your exam that led to that diagnosis? They are probing for evidence at this point. Student says he has a positive impingement test. Preceptor asks, are there any other symptoms or findings in the patient's history to support your diagnosis? They are probing for more evidence here. Student, he said it hurts when he throws and it's a 6 out of 10 on the pain scale. Preceptor, well, you did a good job performing the impingement test. They are enforcing what was done well. Is there anything else you think you should do to help confirm your diagnosis? The student, I didn't really ask enough history questions, and I didn't think to look at his posture either. Preceptor, good job. I'm glad you recognized that you missed those components in the exam. Correcting mistakes, but thankfully the student corrected it themselves. Always remember that it is important to examine the scapulohumeral rhythm in shoulder patients, as poor scapular stabilization can often be a contributing factor to impingement. They are teaching a general rule here. These are our references, and that is the conclusion of preceptor training. Thank you again for your time and acceptance of this task. Please do not hesitate to call either myself or our program director, Dr. Kim Shaw, with any questions you might have this semester. Thank you again and have a great day.